Good afternoon. Welcome to Grand Rounds today. As you know, I always do, I will remind you to sign the attendance record at the back of the auditorium, and then also please fill out the program evaluations that I think you all have. And if you could give us any ideas that you might have in regards to future topics or future speakers, the CME committee is always appreciative. I think most of us have at least some passing familiarity with Candor, and today we actually have two experts. Our speakers today are Kate Strickler. Kate attended Iowa State as an undergraduate and then attended Drake University for law school, and she now is general counsel for the Iowa Medical Society. And our other speaker is Mike McCoy. Dr. McCoy is obstetrician gynecologist and currently chief medical officer at Great River Medical Center in Burlington, and was very closely involved in the development of the Candor program. And so we're appreciative that they both could join us today to update us on the Candor program. And please join me in welcoming Kate Strickler and Mike McCoy.
Well, thanks for the invitation. I don't know, you get used to this, but this is a really nice speaking hall. We've been to several, but there's not too many we've seen that are a little nicer than this. So I appreciate the opportunity to share with you something that is sort of very passionate about, and I think we've worked on very hard at the Medical Society to try to get a pilot site done and to now hopefully get out some education about it. So I'm just going to share with you, and I'm going to kind of open, and I'll apologize to any of the Medical Society staff. I opened with this about a year ago at a Candor conference, but I think it just kind of starts off the tone of what we're going to talk about. So once upon a time, there was a patient named Pat. Pat had an unanticipated outcome. So the questions were asked. Caregivers tended to keep to themselves, minimalized and rationalized while avoiding too much emotion. There was a comment of, "I know how you feel," or "I apologize for whatever happened." Many caregivers are afraid to apologize or discuss at all. No incidents were reported. The family starts to ask questions. Provider denial sets in. Fear and finger pointing cause the provider to contact their insurance carrier. They're told to talk to no one about this, not the patient, partners, or colleagues. Provider distress and isolation sets in. Pat and the family's questions go unanswered. Providers start to experience self-doubt, disappointment, perhaps shame. Pat's seeking an explanation, a sincere apology, and assurance that changes that have been made that prevent harm from being done to someone else. Pat now tries to navigate the traditional litigation system that can be very difficult to access, is not a reliable mechanism for sorting meritorious from non-meritorious claims, and results in wildly varying damages awards for similar injuries. Fear has prompted the medical community to rely almost exclusively on a legal system that does not serve their needs, and it's expensive financially and emotionally. 2 to 4 years go by. After depositions, nothing's been done to investigate, analyze, or possibly learn from this towards quality improvement. Pat and the family are psychologically wounded by the inability to obtain facts in an empathetic manner, with no institutional mechanisms in place to aid providers in the grieving process. They turn to dysfunctional ways to protect themselves, and this distress escalates in the face of a malpractice suit. Once formed and often strong relationships are forever broken, regardless of any trial or settlement outcome, and many times you now have a second victim, the care providers. There's a better way for patients and providers for proactively addressing patient and family needs, for ongoing transparency, for timely resolution, and for quality improvement. Through system solutions and disseminated learning, for focusing on just culture system and human factors, and for maintaining relationships between patients, families, and caregivers, even when an unanticipated outcome occurs. So I think that kind of is what the Candor process allows. Candor meaning communication and optimal resolution. This, I'm going to try to do this. So as said before, I come from Great River Health System. The Candor process started. Task force through the Medical Society was formed and got through the board at the Medical Society. The idea as far as tort reform legislation, and this was one of the things that we wanted to push. That was started in about December of 13. We moved forward. It's now Iowa Code. You can read this. I won't reiterate. With the last passage of tort reform, we did get this updated and expanded. So now it includes any cause of physical injury and all members of the healthcare team. The original version, there were a couple of societies that didn't get on board, so it made it a little hard because the whole team maybe couldn't be involved in this. We have set up a team, and what happened with us is with Kate and some members from our team at Great River, we went through a CRP training at Stanford. That should say Stanford, not Sanford or Sanford. We didn't go to Sioux Falls. But we went there in February of 16 to do the training, and we can talk a little bit difference about what's CRP and what's Candor. They're sort of the same, but Candor just kind of refers to the law, and we'll talk about that. We came back to the health system, and we set up this team. We have a way of implementing it by just secure messaging, and I'll go over that in a minute. And so we formed a team, we developed some structure, we formed a policy at the hospital, we had help with the Medical Society. I started with a board presentation. It kind of has to get leadership down to buy into it or it's not going to work. I did a board presentation, talked to the medical staff, talked at service meetings, our medical practice committees, our medical executive committee, our quarterly staff meetings, then went out and talked to all the hospital staff, all the nursing staff, directors, supervisors, and managers. It took a little bit of time. We were originally planning on starting until July 1 of 16. We thought that'll give us about 4 months after training to get some things in place, which we thought was pretty vigorous. But once we started going out and talking to staff and to providers, we started getting calls. And so we thought, well, here we go. Dr. Booth at our training said, there's a lot of stuff to think about, and if you overanalyze this and make it harder than it is, you'll never get started. He said, it's not that hard, just go do it. Now, having said that, I will say I think a bad disclosure is worse than no disclosure at all, so we'll caveat that a little bit with that. But we started our program April 1st of 2016. We did teaching to the staff that if there's anyone that thinks that there would be a Candor event or a CRP, that all they have to do is pick up their phone, secure text Candor. It would go to all the members of the team you saw there. We're somewhat of a small health system. We have about 80 employed physicians and about 60 employed advanced practitioners with some other non-employed staff. But we then the members of the team will get together and figure out who's got time to go deal with this, because timeliness is very important. Many CRP events are not Candor events. So there were a lot of things that happened in the health system where we would just go and initiate the conversation and deal with the problem and just kind of tell patients what you know when you know it. And we had several things that happened that we dealt with that didn't really involve Candor. Fortunately, the wrong site knee surgery was an arthroscopy, and the guy was just happy because he got both knees hurt, and the lesser knee he got done free, and then we did the other knee later. But we've now been through 8 completed Candor meetings, and this is the process whereby we usually don't. We mention Candor and what it is to patients when an appropriate case comes up. And then once I think they get comfortable with us and genuinely wanting to help them and have their best interests in mind, there's some formal paperwork and stuff that's done to protect everyone legally, and I'll have Kate go through that. But we've had 8 completed cases now, 5 of those with a financial resolution. We have 6 of those patients and families are still in our health system, and that doesn't happen through the other channels of malpractice suits. 1 had moved out of the area, 1 we're not certain, we've kind of lost a follow-up. We did have 1, we now have 2 in process that are being set up, and we had 1 that we just finished that no financial offer was made, and we'll see how that goes. Some of the services involved you see listed here, and having updated this recently, that would now also include a family practice, a clinic, and an outreach clinic. Some of the process improvements, and I think if you go about this as a strategy to save money on your insurance, you'll fail. While all the recent literature will state that at worst it's a break even, there's a lot of literature now that's coming out showing that there's a lot less money spent on malpractice insurance, the time it takes to get claims settled, with the cost to defend cases. Iowa and the upper Midwest had the second highest cost to defend a case next to Illinois in the whole upper Midwest as of about 2 or 3 years ago. But these are just some of the process improvements that have been put in place for us during this process. And a lot of these were part of the resolution. Sometimes what patients want is money. Sometimes, they come in and they're angry and they want you to die, and you kind of got to get through those initial phases of grieving until things can settle down. And at the end, what they just want to be is they want to be heard, and a lot of times they just want to make sure processes have been put in place so that things that happened couldn't happen again. So there were several things that we had done and changed through this process, and I'm not going to necessarily go through and read all of those. One of the patients that was involved in a Candor case is now on our patient advisory council. I think thinking about the idea of how things are done in their traditional system is you tend to not talk about it. Things don't really change. You deny, you defend. Usually physicians and nurses are the root cause. It's all about usually that doctor or that nurse. If they wouldn't have done that, this wouldn't have happened. Relationships are almost always severed, and sometimes family relationships, and sometimes the patient, their family, and all of their family. And so it escalates in small towns, as you know. And then occasionally, 3 to 4 years later, you might get in a resolution. I think the latest statistics I saw for someone that practices for 40 years, they spend 11% of their time in the middle of a lawsuit that's either ongoing or has not been settled. 83% of us will face a lawsuit at some time in our career, and then by specialty, I think average for OB-GYN now is 3, which is why the average age that an ACOG member stops doing OB is 48 now. And then the whole second victims thing. A lot of times with the isolation, you're not supposed to talk to anybody, and anybody that's experienced that or is going through that, it's difficult to have your colleagues going through that and you don't even know it. What we're looking at is prompt disclosure. We try if we have an event. I got a few months ago one of my colleagues, partners in family practice clinic, contacts me on the Candor and sends me a secure text. He says, "Give me a call. Hey, I think we've got this possible Candor case. It's something that happened as a surgical thing. The patient's upset. The surgeon didn't even know about it. Something that happens in the hospital, we get to them right away. We try to get to them as soon as possible. We start making contact. We make sure they know who the contact person is. So we do prompt disclosure, continuous improvement, trying to learn the lessons. We're very transparent. We try to share facts. If we don't know, we're saying, hey, we're going to investigate that. We're going to get outside help, and when we get the information, we'll share it with you and we'll sit down and go over it. We try to focus on just culture. Almost all these cases, it's not one person, it's not the doc, it's not the nurse, it's usually the system, it's usually the culture. Once in a while, a little more of an emphasis may be put on one person, but we try not to focus on that. Almost always the relationships have been maintained. In all the cases that we've done with Candor, there is one patient who doesn't want to see one physician, but still comes to the health system and sees everyone else. Every other relationship's been maintained. The main thing, I think, is trying to give support to the family and to the family members during the process, and to let them know they're not abandoned, and you're keeping communication open. I think just trying to be treated how you'd want to be treated. Our goal is you'd want to have resolution within 6 months. And I would say the majority of ours are probably done within 4 to 6 months. I don't know of anything that's gone after 6 months. We have a Care for the Caregivers program. I sort of am aware of everybody that's been through things and what they've been through. And, we'll have little side cups of coffee and chat and see how they're doing. When it gets a little beyond that and I can tell somebody's really struggling, I've got one of my psychiatrist colleagues who sees other colleagues and providers sort of during his lunch hour before and after clinic. It's not official, it's sort of just knowing that there's help there. And that's been very helpful. So what patients want is the truth. They want the facts. They need emotional first aid, that they're not abandoned. There's accountability, including an apology. Apology laws, and I'm sorry, doesn't cut it. And there's some statistics, and I can go over later if you want how many states have those. But that just doesn't take care of what you need for to be comfortable to do this. They want to know that there will be a prevention of recurrences, and then remediation. And so our philosophy is sort of we will compensate quickly and fairly when inappropriate medical care caused injury. Sometimes we'll just tell patients, this wasn't our best. We kind of messed up. We're going to fix it. But on the other hand, we support our staff very vigorously when care was reasonable. And we've had times when we had to tell patients and families, I think our staff did the right thing. We think our care was good, and we're just going to have to agree to disagree. Kate will correct anything I say that's wrong later, but I think the last figures I heard is only about 6% of cases that go through a Candor process will fail and go on to litigation. So, and then the main thing with this is looking at it as a patient safety and a quality initiative, trying to reduce patient injuries and claims by learning from our experiences. So we did have a big conference about a year ago to kick this off in Des Moines. We had about 100 attendees, and they were providers and lawyers and risk managers. The Medical Society is now partnering with the Iowa Healthcare Collaborative and coming out with some toolkits, some teaching, and to try to help get some other sites involved in this with some training and some national experts. I think one of the struggles is finding lawyers who will support this paradigm shift and changing the status quo. And every time we have a patient that goes through Candor, we require them to have an attorney that represents them. The last thing we want to be accused of is trying to, you're just duping somebody and getting them through a system and paying them something that they wouldn't have otherwise been able to get. So we make sure they have a lawyer that represents them. We've been able to use one that's got quite a bit of experience. We're trying to get her convinced to work by the hour and not on a contingency fee, because she spends a lot less time working than she would have as a plaintiff on a case. Current medical liability insurers in Iowa that support Candor are COPIC, MMIC, Pro Insurance, MedPro, and CNA Global. I think that's supposed to be CNA.